webinars, and it's indeed a great pleasure to bring with you my team and friends who are experts in infection control. Let me start with a big salute to our real heroes. We lost some of them and numerous others are in the front line. In spite of what the society gives us, we will continue to treat every patient with dignity. Tirukural, which means that the punishment to those who have done evil to you is to put them to shame by showing them kindness in return, and to forget both the evil and the good done on both sides. With this, I start my presentation on infection control practices in eye care during and post-COVID pandemic. Along with me, we have a galaxy of speakers who have already been introduced. I'll be talking to you on the basic concepts of infection practices, and we all know we are in lockdown, so we are confined but not broken. So in these times of enforced lockdown, we may sometimes lose hope. When are we going to start our practice? When are we going to go back to our normal self? And there's a lot of despair and pessimism slowly enveloping us. But the secret of getting ahead is getting started. And there are a lot of positive things that have come out of this pandemic. And I'll start on a positive note. A lot of collateral gains from catastrophe. And all these we were trying to inculcate in our civil society. No spitting, no crowding, queuing and self-distancing, and the Namaste concept, washing hands frequently, surface cleaning of vegetable, whatnot, lot of other collateral gains. Some of our bad habits have taken a hard knock from the virus. But for me, the most important aspect as a assessor as well as a practicing ophthalmologist is the renewed and keen interest in infection control with the ophthalmologists as well as the medical professionals. Novel coronavirus infection, I know it is a new one, but lots of abundant materials and resources. Some are evidence-based, some are experience-based, some are observation-based, and many of them are hypothetical. So we don't know what is exactly about this virus. But the guidelines that has been given by the WHO, CDC, and the Ministry of Health, NCDC, and now AO has given elaborate guidelines. As told by Dr. Mahipal, the guidelines are dynamic process and have to be updated periodically because we are learning something new about this virus from the nooks and corners of the world. Of course, in spite of all these resources, we are in this state. We don't know when the vaccine will come. We know which therapy is working well for somebody. There are some group of people telling about yoga and meditation. There are some detailing that Indians are protected by the BCG vaccine. Still, we have yet to come to the conclusion. So my talk will focus on the IPC program and all the relevant program linkages. So to start with, if you want to learn something, we have to go to the basics, what really happened during the earlier pandemics, and what we know about this virus. Of course, this family virus, we know the HIC principles from the NABH standards and few other standard guidelines, and what are the protection and barriers available, and how we train our people, and also how we monitor them during the pandemic as well as post-pandemic, and how are we going to audit these things, and how triage and OPD protocols will help us. So we need to have an enabling environment to see to that these guidelines are working well, and the education training by the staff to the staff is going to work or not. So pandemos means everyone getting affected, and just a quick look into the world's worst pandemics. In 1918, 102 years back, we had the world's most lethal pandemic ever. It started in March 1918. Within 1 week, spread to every state of US, and those who fell in the morning were dead by night. And by April 1918, in 1 month, the virus has spread to Europe, China, Africa, and South America, in spite of the transport and travel facilities that were lacking. In 6 months' time, there was a second wave called as the main wave, and this second wave killed 1 lakh. So that is the reason why we should not be lax, even though the severity is less. By 1919, the flu literally vanished in 18 months' time, and the mortality rate was very high, more than the Black Death called Black. The first time, the US life expectancy went up to 38, and of course, later on it climbed back. So this pandemic has always been due, and it tends to occur in cycles. There was no major flu pandemic since many years. Probably it was due, and we are still underprepared. We probably didn't expect this so early. So these are the viruses causing RTI. You know that rhinovirus is the commonest element, and coronavirus is known to be causing respiratory infections. The other strains of coronavirus, these are the known strains of human coronavirus. So this makes things extremely difficult in detection as well as finding a vaccine, because this virus is going to mutate very frequently. So the standard precautions also evolved with the understanding of pandemics. So with HIV pandemic, the universal precautions came into vogue, and after 2 years, the body substance isolation. This actually helped us to control the HIV pandemic in a great way. And in 1996, after this MERS and SARS and few other epidemic, the standard precautions came into being, and the principle called transmission-based precaution was also introduced. So with coronavirus, this standard precautions and universal precautions are going to be updated with new learning and new principles. So whenever you want to give in some infection control and prevention measures, you need to understand the pathogenicity, virulence, invasiveness, and specificity. These 4 things are really important. So unless you know this, it's very difficult to devise an infection control mechanism. So you know this morphology, you would have seen this virus, and it's a very large virus, so that means very easy to filter. And you also know the 4 stages. The one thing that really makes this virus control difficult is a long incubation period and virus set in all stages and a lot of asymptomatic carriers. So this is very important to be kept in mind when you want to devise an infection control mechanism. You need to know the disease transmission cycle and how to break this chain. We need to have a good sterilization and disinfection method with a foolproof to really break the chain. We need to know the agent, understand the dynamics. Basically, the viral agents are transmitted by 3 mechanisms. One is contact, second one is droplet, and third one is the airborne mechanism. The contact infection can be handled with good hand hygiene, gowns and gloves, barrier methods. The airborne infections can be again handled with hand hygiene, negative pressure rooms, and N95 mask. And droplet infection, of course, that's what government is telling now, mask for everyone and hand hygiene. And these are the list of infections we have come across in the last 1 year in many of our hospital practices. All of us would have gone through this type of pathogens on the environmental surface. Into COVID-19 belong to influenza, where it can stay in the environmental surface for up to several days. So we know something about environmental disinfection, so we need not panic. So what are the guidelines? The national guidelines for infection prevention was supported by the WHO and various other organizations. These are some of the patient safety framework that's existing. But all these framework based on these national guidelines, education and training to the staff and the healthcare people, surveillance by the administrative authorities and hospital leaders, and multimodal strategy. It's not only the medical part, the public health part, the epidemiological aspect, the engineering controls. All these plays a major role in control of infections. And of course, we have to monitor and have to know about the outcomes. So NABL standards, you all know that there are 10 standards. But with reference to hospital infection control, there are 2 important standards. The HIC standard, which will be Dr. Gagan will be discussing, and the facility management and safety, which actually helps to understand and control the virus by barrier method. So this is the most common adverse event in healthcare, but it can be preventable through HIC measure. So the first step in establishing a proper program across the hospital, you need to have a committee. And this committee will understand about the virus prevention and control program, and it will be documented. In NABH accredited hospitals, this HIPC program would have been documented now, and the only thing we need to update with the COVID measures. So what are the objectives? Protecting yourself, protecting your patients, protecting your family, the community, and environment. By now, all of us would have been familiar with this epidemiological curve, and the government is so intense about flattening the curve. Another curve that needs to be studied in hospitals is this curve, where the red triangle indicates minimum and the full protection. So this curve is very, very important. So all hospitals need not have the full requirements, but if you start with and go through minimum requirement, that is more than enough for controlling and preventing infections. So these are the accreditation standards under the NABH guidelines. And what it means is you need not have full protection in all the areas, in all the setups, in all the facilities, except for ICU or ITU units. So this is the hierarchy of control. So whenever you have a infection, the best method is elimination. That may not be possible all the time. And the second one is substitution, replace the hazard. And third one is the engineering control. Engineering control is basically positive pressure rooms or negative pressure rooms, what we have in the operation theaters. And the administrative control, very important, change the way people work and how we train them. And last thing is the PPE or the respirator, which are also very important. So OPD areas may need similar situation. We all know how our OT is protected with not only medical control, but also engineering services. And this is the ideal airflow that has been advocated in our operation theaters with the help of filters. But in our OPD, it's chaotic airflow. It's very, very difficult to bring into a laminar airflow or a controlled airflow mechanism. Somehow we need to bring this into our OPD areas and other areas also. So how do we establish this? One thing is natural ventilation. So open the windows for ventilation every 15 to 30 minutes for fresh air to come. And UV disinfection twice a day has been advocated when people are not there. So this can be done. And a lot of other engineering controls are coming up. One is ultrafiltration that can be incorporated in our air conditioned rooms, HEPA filters, 14, nano and agape filters. So how do we assess the risk? Who is at risk? All of us are at risk. What is the level of risk? You need to understand. What is the level of risk to the staff, patients? In eye care, the level of risk is relatively less compared to a multi-specialty hospital. But our preparedness is also has to improve. How we can do that? You have to understand who is at risk. Of course, everyone at risk, but this particular group is at, so we see the casualties and fatalities among the healthcare people. So we have to protect this special group, doctors, nurses, and healthcare staff by our IPC mechanism. So all patients at all times, regardless of suspicion or confirmed status, have to be suspicious. So this is a cycle, and these are the human resource needed for infection control, provision of adequate training for healthcare workers, ensuring adequate patient to staff ratio. This is going to really take a difficult thing on us. Establishing a surveillance process. Our quality system have to be made more stringent and ensure that the healthcare workers understand the importance of hand hygiene and using PPE, and they have to be monitored. You need to have good supervisors and staff who can monitor the usage of PPE, and we also need to get a lot of feedback so that we can retrain them. Triage is very, very important in the OPD setup. I'll come to that later. We also need to understand when we're coming to triage, what are the common presentation symptoms. If we can filter the top 3 or 4 group of patients with those complaints, you are reducing the risk at our hospitals. Triage, early identification, and source control is an important mechanism of infection control. We have to start with hand washing for everybody, temperature screening for everybody. Hand hygiene and PPE, of course, it is the lower end of the pyramid. That is very, very important, and we have to teach our people with good hand hygiene, and we also need to have some mechanism to see to that the hand hygiene is perfect. This is the overview of PPE. Of course, my colleague will be covering this. And you also need to understand how long the coronavirus can live on surfaces. This is very, very important. Outside the surgical mask, it can stay up to 7 days. And that is important to dispose this mask, not only for in the healthcare situation, but also outside the healthcare facilities. Disposing these masks is going to be a great difficulty. And this is the overview of what are the environmental cleaning and disinfection needed. We have to classify the areas into high risk and low risk. And of course, common disinfectants, one saving grace is the common disinfectants like sodium hypochlorite and ethanols are really effective. So overview of this entire hospital infection control method, you need to start with disinfection, decontamination and elimination. This would be the key activity. And you need to have a mechanism for physical and ventilation barriers. And the containment is very important. That is the reason government is advocating stay at home. And triaging very important in institutions like eye care institutions. So based on key principles, you need to focus on hand hygiene, respiratory etiquette, droplet precautions, HIC, the standard and universal precautions. Protect yourself, staff and the community. Triaging is very important. Judicious and appropriate use of PPE. It is very, very difficult to source PPE nowadays and it's very costly. So you need to have appropriate usage. Pay attention to donning and doffing. My colleague Rajiv will cover this, and home care precaution also is important. So with this, I end my talk. The guidelines are dynamic process. Let us continue to learn so that we can apply these principles in our setups. Our setups are from small hospitals, one-man clinic to large hospitals. So we have to understand the principles and guidelines and devise our own SOP to the benefit of our own institution. Thank you so much for your kind hearing.